Welcome to everyone to this presentation on early intervention for deaf and hard of hearing children, tips for parents. I'm really happy to be with you tonight. It was funny when I was prepping for this, I realized that I have been working with the deaf community for nearly 40 years. So I hope I have something valuable to share with all of you this evening. Okay, Liz, I think you have charge of the PowerPoint. So if you can go to the next slide, that would be awesome. All right, so what I'm hoping to accomplish tonight are the objectives you see in front of you. You know, when Liz and I were talking about this, one of the things that happens for almost all children who have a hearing loss of any kind to enter the system is they're evaluated and assessed. And I wanted to talk a little bit about that because I'm not sure that people always really understand what those are, or even that they're not the same thing. Another objective is to help you understand, at least at a beginning level, the importance of early intervention for brain development. I also want to highlight some of the developmental milestones and how they differ in children who are deaf and hard of hearing, and help parents to kind of trust their gut about when should I be concerned and when should I not be concerned. Also, I've noticed more and more that birth to three providers for deaf and hard of hearing children really focus, or I would say hyper focus, on language development to the exclusion of other areas. And I wanted to highlight for you that language should not be the only area for intervention. So on the next slide, and we're going to begin each of these objectives with kind of a series of questions. And this is where audience participation is invited. And, certainly I'd be interested in hearing the participants, all of you, what your experience has been. But I want you to think about these things. At what age was your child assessed? What prompted that? Who prompted that? Who completed the process? Where was it completed? Who was with your child for the assessment? What was your role as a parent or caregiver? And did you have to fight to get the assessment to happen? So would anybody like to offer their perspective on that? Well, given the radio silence, I'll fill in the blank a little bit for you and tell you what my years of experience in the deaf community have been. Very typically, it's a mom or dad that is the one who's concerned about their child in terms of hearing loss. Those are the two most common caregivers who have those concerns. And what I find is that that's anywhere from birth to age 3. And unfortunately, as you'll see later in the presentation, age 3 can almost be too late. Who completed the process? Well, a lot of times I find that parents are given information such as, well, your child's not babbling, don't worry about it. Some kids don't babble. Your child's not saying words by about 12 months, don't worry about it. Some kids just talk late. Those types of assurances from pediatricians are actually very misleading. To give you a framework, in the years it takes to become a pediatrician, pediatricians receive 1 3-month class in normal child development. Yeah, you heard me correctly. 1 3-month class. So when they're saying that they believe your kid's going to talk later on, they really believe that because they really have very little training in normal development and normal developmental milestones. The most common people to complete the process of the assessment are birth to 3 providers. And as all of you parents know, and the providers in the audience know, there are a number of different birth to 3 providers in the state, and they can have a very different bias based on, well, realistically, based on the training of the people in the program. Now, birth to 3 is supposed to be neutral. It is not supposed to be biased. But let's face it, humans have biases. So also what happens for most parents is that that assessment takes place in the home. And that's kind of a double-edged sword. That's a good thing because that's usually where your child is fairly comfortable. At least we hope your child's comfortable in their own home. But that also means that the child has already picked up cues, regardless of their hearing status, from the environment. So sometimes what happens in my experience is that a child exhibits behaviors that they will only do for a caregiver, only do for a mom or dad, and they won't do for anyone else. So you could have someone who says, mom or dad, please stand to the side, so your child looks like they're not as able as they are, or the opposite happens. I do find that most parents, most caregivers have to fight for this evaluation to take place. Despite the fact that we have child find required by the state and federal government, parents usually have to fight for these assessments and evaluations to take place. Okay, next slide. So, assessment and evaluation. These are terms that are typically used interchangeably, but they are not, in fact, the same thing. They're sometimes just referred to as testing. Here are the differences. Assessments are ongoing. That means I'm looking at the same thing over time. All right. An evaluation, on the other hand, is typically a one-shot deal. Now, I say a one-shot deal, but it may take place over a number of visits to a provider, but it's using typically standardized test measures of some type. And it is looking to describe the functioning of a child from, I refer to it as one frame of a movie. Because let's say the day that I'm there to do the evaluation with your child, what happens is that your child's not having a good day. They don't feel that well. They have an earache coming on and they're not showing any signs of it. So you do that evaluation on that day, and sometimes what you end up with is you end up with something that may be less than valid. But it's very important to understand that most birth to 3 services are in fact an ongoing assessment. Each time they visit your child, they're assessing. How does your child look in comparison to the last visit? The same is true of preschool programming and kindergarten programming. By and large, those are ongoing assessments. While a teacher in a preschool or a kindergarten program might do a beginning of the year evaluation using a standardized test and may repeat that at the end of the year to document growth and progress, typically what's happening the entire year is there's an ongoing assessment process happening. Please, if you have any questions at any point during this, stop me. All right, so let's go to the next slide. The next slide is looking at, so what do we use for assessments and evaluations? Most common for birth to 3 providers are checklists and rating scales. See, developmentally, we know that by certain ages, most kids are doing certain things. I'll use language as an example, though again, this should not be the only thing that's being looked at. But checklists would say that most children by between 4 and 6 months are beginning to babble. Developmental norms would also say that at about age 12 months or 1 year, one word telegraphic speech or telegraphic sign is what's happening. That means if I say outside or I sign outside, it means mother, put on my bathing suit. It's very warm out. I would like to go under the sprinkler. But all the child signed or said was outside. By age 2, typically kids are able to put 2 words together, as in milk, please. By age 3, 3 words together, mommy milk, please. So if that's not occurring, then you're outside the developmental expectation for a child of that age. And that's very important when we're looking at checklists and rating scales. Rating scales are things that are norm referenced. Norm reference means, you may remember the normal bell curve. There's this idea that if you take any trait and you graph it all out, what you're going to end up with is what's called the normal bell curve. Rating scales are norm referenced. It means that we know that clustered around the middle of that bell curve is about 66% or 2/3 of most people. So what that means is that if you're doing a rating scale, you're checking off what your child does, or you're saying they do this a lot, they do this very little, they do this not at all. And that's, again, based on observing lots and lots of children at the same age. More typical in evaluations are standardized tests. These are tests like IQ tests, achievement tests, and it's very hard to do those with very young children. So a lot of what's done are checklists and rating scales, and also observations. When I do an assessment of a very young child, I'm looking as much at how they approach something, problem solving, play, running across the room, as their actual ability to do it. So I'm looking at it from a developmental perspective. What would I expect another child at this age to be doing? And I'm also looking at it informally. Informally meaning I'm not necessarily tape recording this child and then looking at a child running perfectly and examining the two sides side by side. So a lot of assessment for very young children is in fact quite informal and primarily based on checklists and rating scales. Okay, next slide. Whatever we do, when we're doing either an assessment, which remember is ongoing, or an evaluation, which is a one-shot deal that may happen over several days, but is going to give you data that's based on the normal bell curve, it has to be valid. Valid. Valid means that whatever measure we're using measures what it's supposed to measure. Best example I can think of is IQ tests, okay? IQ stands for intelligence quotient. Intelligence quotient. It's a number somewhere between, depending on the test, 0 and about 150. where you're comparing the child you're evaluating to other children who have already taken the test. And it's considered valid because we believe when we give you an IQ test, we're measuring innate ability. That means ability that the person was born with. There's a lot of debate in my field of psychology about whether or not that's actually true, but that's the idea. Now, the second thing is that whatever assessment or evaluation you're doing must be reliable. That means I have to be able to know that I'm measuring the same thing over time. Because again, using the example of IQs don't change a lot over time. An IQ changes maybe 3 to 5 points, which is within the test parameters, but they don't change by 50, 60 points unless there's something really wrong. So it's really important to understand that whatever is done needs to be valid. It has to measure what we think it's measuring, and it must also be reliable. That is, when we use the same measure at another time, we're likely to get similar results. Okay, nobody's stopping me, so I assume you're all okay and following me. All right, we'll go to the next slide then. So here's what I want you to know about assessment and evaluations. Most formal measures, standardized testing measures like IQ tests, are not truly valid until the age of 7. Let me repeat that for emphasis. Most formal measures are not truly valid until age 7. Well, why is that important? That's important because what sometimes happens when we're testing a very young child is that very young child has what we call splinter skills. Splinter skills means they have some very, very high skills in one area and some much lower skills in another area. And if we happen to be measuring the very high skills, then what we look at is okay, is that really how that child functions? Or did we just happen to hit on a skill they're really good at? That can happen. On the other hand, did we test something that the child is not good at? Because IQ being an example, IQ tests also are dependent on to what has the child been exposed. And as you as parents and providers and caregivers of young children with hearing loss, you know that their exposure is limited to some of the same things that hearing kids just come by naturally. But these evaluations and assessments are helpful. Here's what they're helpful for. They help you plan treatment. And I'm referring to treatment here using a medical model. So treatment might be that in the process of this assessment and evaluation, we realize that your child has more earaches and problems with hearing because their ears get blocked by fluid when they're drinking dairy products. So we stop that, and that medical treatment addresses part of the problem. These assessments and evaluations are also helpful for education and for globally programming for the child. You know, one of the biggest parts of programming for young children is play. So how do we help young children play as a method of learning? And educationally speaking, we want to make sure that we're going ahead and giving them the information, that we're giving school districts the information they need to plan a program. Now, as a psychologist, I can provide a diagnosis. As a school psychologist, I provide a category of exceptionality. Sounds like double talk, but it's really not. A medical diagnosis, for example, would be intellectual developmental disability or autism spectrum disorder. A category of exceptionality would be intellectual developmental disability or autism. Did you see the overlap? In the first area, there's overlap. In the second area, there's not. Autism spectrum disorder and autism are not the same thing. Autism is a category under special education and disability law, whereas autism spectrum disorder is a medical psychiatric diagnosis. And that's important because sometimes parents get what's actually a medical diagnosis, and then they try to bring it to the school, and the school says, well, that's useless to us. You bring it to the preschool provider, and they're like, well, what does that mean? It's not any help at all. What ends up happening with both of these measures as children get older is they are expert driven, as in the experts at the school do the evaluation. And they're based on the medical model. A lot of things in our world are based on the medical model. Now I see that the number of chats going up has gone up. Does anybody want to share what you're chatting about or ask a question based on something in the chat? Make a comment.
Hi, I'm Pat Stavola.
Hi, Pat.
And I just mentioned when you were talking about IQ tests before, my son does not have a hearing loss, but he is ASD, and he's an adult now. But when he was first tested, his IQ was fairly low, but it went up by 20 points at each triennial. So an 8 is not really correct. It really was as much as he was interested in answering whatever they were asking, and his language skills increased so much. So
Pat, absolutely. You're absolutely correct, which is one of the quandaries in my field is, are we really measuring innate ability, or are we measuring the ability of the schools to provide better services?
That's interesting. That's an interesting point. I like that.
Well, because one of the things, Pat, that I've noticed over the years is that children who score, in order to be diagnosed with an intellectual disorder or an intellectual developmental disability, the category of exceptionality we used to call mental retardation, you have to have an IQ below 70 prior to the 18th birthday. So what I was finding was that kids in elementary school, which is typically when they're tested, were coming out with IQs of 65, 67, 62. But then by the time they reached middle school or high school, they were getting IQs 71, 74. And the problem is that we had done such a good job in our educational system of teaching them the things that the IQ tests measured, that they were basically being cheated out of adult services because they didn't qualify anymore. Right. They didn't have an IQ below 70.
Well, I mean, that's not true of my son. My son doesn't have an IQ below 70, but I don't think he's been cheated out of anything. As a matter of fact, when he was tested first with me, he was actually, I got him when he was 9 years old. And the school psychologist here in my town said, he's testing below 70, but don't believe it. He's way smarter than that. And she recognized it in him after having worked with him for only a few months. And she just said, he's just not into testing, or he doesn't want to be tested. So that was his issue. Now he's doing great now, and I don't think he's missing out on services, but there are kids who are closer to the borderline that do miss out on services. I hear from people every day about that. Yeah.
Yeah, and that's partially because of how well we do in our educational system of remediating those intellectual cognitive deficits in kids who are at that borderline. But what that translates into is a dearth of services for somebody who has, because functionally, what's the difference between a 68 IQ and a 71 IQ?
Exactly.
I mean, in terms of how I function on a day-to-day basis, there's no real difference. And the category of exceptionality of autism, and in terms of how people with autism spectrum disorders function, is we're finding more and more that they do better across the lifespan. And
with early intervention, yes.
Yes, absolutely. And the earlier the intervention for any disability, the better off you're going to be as time goes by. Well, thank you, Pat. Other people want to make a comment? All right, let's move on to the next slide. So this slide, again, is an opportunity for some audience participation, some things for you to think about, because all of these things relate to brain development. Think about, what is your child's favorite activity? If they're given a choice to go do anything, what will they do? Which is their dominant hand? And we don't only have a dominant hand, we have a dominant foot and we have a dominant eye. What activities does your child shy away from? When do they act fearful? What makes them tired? What winds them up, like, as my grandmother used to say, a $2 watch? What soothes them? Anybody want to offer an answer to any one of those questions?
I'll start again. Everybody's being shy today. When my son was young, at the age of 3, and that was before he was living with me, his favorite activity was to line up his trucks and spin the wheels.
Okay.
And he would just lie there for hours watching those wheels spin.
And that is a very common activity for kids who will later be diagnosed with an autism spectrum disorder. How many of your children, I don't know if there's a hand raise function on this, but how many of your children are left-handed? Are left-hand dominant? Think about that for a minute. How many of how many of your children are ambidextrous, as in they do some things with their right hand and some things with their left hand, but don't seem to have a really apparent preference?
This is Alvin here. I would say mine is left hand dominant.
Okay. How about foot? Which foot is dominant? Easiest way to tell that is when a child approaches steps, which foot do they use first? By the way, one of the ways to increase your brain flexibility is to notice your own foot dominance when you approach steps, and make an effort to use the opposite foot as your dominant foot when you approach the steps. Does everybody understand what I just said? When you're approaching the steps, let's say you would normally always put your right foot up. If you want to gain greater brain flexibility, the next time you approach the steps, force yourself to put your left foot up first. However, don't trip up the stairs, because sometimes when we're trying to do that, when we're trying to increase our brain's flexibility by doing something simple like that, it's very easy to get discoordinated. Any of you swimmers, If you're a swimmer, you know when you're freestyle swimming, your head always comes out to take in air the same direction. Well, try taking your head out of the water the other direction. You're likely to get a mouthful of water the first few times you do it. But that increases the flexibility of the brain. And, think about what activities your child likes, what they don't like. But even more important for brain development is what winds your child up and what soothes them. Because all of us were born with the ability to self-soothe. But many of the activities that we use to self-soothe as babies are not socially acceptable. It's not okay to suck your thumb in public. We don't like that. So, we tell kids, get your fingers out of your mouth. And that's a problem, because that could be a soothing thing that a child needs when they're afraid or tired, or, to avoid getting wound up. So next slide, let's just talk about the brain a little bit. So the brain of an infant is approximately a third of the size it will be at the time. The brain of let me go back. The brain of an infant is about a third of the size of the body when it's born. Okay. So think about that. When you see an infant, their head is about a third of the whole body. And what we know is that between birth and age 7, we have the most rapid development of the brain that your brain is going to experience for the entire lifespan. We also know that infants are thrill seekers. There's a reason newborn babies and infancy is essentially birth to age 2. There's a reason they can't move a lot, because they're thrill seekers. If they could move, they would hurt themselves. Case in point, the other end of the lifespan. At the other end of the lifespan, we have people who develop neurocognitive disorders, what we used to call dementias. And what we find is that people lose their brain capacities in the order opposite they learned them as babies. So let me explain what I mean. When an infant is born, the first thing it does to get attention is it cries. Well, it's not crying because it's thinking I want attention. It's crying because it's uncomfortable. The baby is uncomfortable. It's wet or soiled or hungry or bored. So they cry. And what happens? A caregiver comes in the room. Very quickly, the baby remembers. They remember, oh, wow. When I did that, every time I do that, somebody comes in. Then they learn. They learn that if I cry because I'm hungry, they give me a bottle. If I cry because I'm wet, they change my diaper. But if I cry at 2 o'clock in the morning because I'm awake and bored, they'll still come. So they learn. So first first actually they paid attention, right? Because they paid attention that somebody came in. Then they remembered, then they learned, then they problem solved. So what happens is that at the other end of life, we lose our problem solving skills. Then we lose our ability to learn. Then we lose our ability to remember, which is usually where people pick up that there's a problem. Then we lose our ability to pay attention. Infants are developing the first 3 of those skills: the attentional skills, the memory, and the ability to learn. And they do that by things like playing with your keys. You put a little kid in a seat by the table, and you give them food, and what do? They squish up the food and they throw it on the floor. Well, they're trying to see what's going to happen. They're checking out textures and temperature and taste, because of course everything goes to their mouth. All of that is normal behavior. And unfortunately, if we live long enough to develop a neurocognitive disorder, you may see the same behaviors in us as we get older. Now, here's what we know about language in terms of the brain. There are two areas, and those of you that are looking can see that I'm pointing to the temporal areas of my brain in the front of my head, okay? And there's two areas. They're called Wernicke's area and Brokaw's area. Brokaw's area, there's one on each side. Wernicke's area, there's only one on one side of the brain. These are the language centers of the brain. They're the parts of the brain that allow you to hear differently than what my dogs hear. My dogs hear blah, 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 treat. Blah, 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 squirrel. Blah, 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 food. Because they have a limited capacity for vocabulary development. Here's what we know is that by age 3, babies have all of the language structures of their native language imprinted in their brain. Infants are born with the capacity to speak any human language, to use any human language, gestural and otherwise. The reason we develop the language that we do is because we're around people speaking that language. So the ability to process an accent, say from another part of the world, or to speak in the guttural tones maybe of my ancestors in Germany is not there, because by the age of 3, I was only exposed to English. We also know that the language learning window is pretty much closed by the age of 7. And what I mean by that is that after the age of 7, it's very difficult to learn another language. Think of any of you who have tried to learn to sign, or trying to learn to speak Spanish or speak any other language as an adult. It's very, very challenging to do, because the Wernicke's area, the Brokaw's area are pretty much set by the time you're 7 years old. That means that the neural foundations of language have been established. That means the neurons that connect are all already there. Somebody's in the waiting room. I'm going to see if I can let them in. All right, I just clicked to let them in, so we'll see if they're here. All right, Liz, you want to go to the next slide for me? So how do we make a brain smarter? Well, brains require stimulation of the right kind at the right time at the right level. Let me repeat that. They need stimulation of the right kind at the right time at the right level. As in, too much stimulation and I can't take it in. If I'm stimulating you before your brain is ready for that task developmentally, I can stimulate you all day long. And the right kind of stimulation. Well, I can overstimulate you, I can understimulate you. Or is it, like the Goldilocks and the 3 bears? Is it just right? That's what you're looking for, is a just right level of stimulation. And I want to go back to the right time. We have, for example, most kids are toilet trained somewhere between the ages of 2 and 3 years old. Female children tend to toilet train quicker and closer to age 2. Male children tend to be toilet trained closer to the age of 3. So when I have a parent who says to me, well, Dr. Lisa, I've decided I'm going to toilet train my 9-month-old, I'm like, really? huh, that's not the right kind of stimulation, and it's not at the right time developmentally. You can try all you want, but the likelihood that they biologically will have control over their bodies enough to be toilet trained at 9 months, that would be very unusual. Are there not outliers, as in kids every now and then that do toilet train way before then? Sure. But that's not normative. That's not typical. And most of us were typical. Here's the other thing you need to think about as parents of children who have some sort of hearing issue is that brains are born with preferences. And those preferences have to do with how we learn. To put it very simply, most people learn in one of two main ways, visually or auditorily. But it is possible for a child who is born with a hearing loss to have a brain that's born with a preference for auditory input. Just as it's possible for a child who is born blind to be born with a brain that has a preference for visual input. We also learn across modalities. I'm going to explain what those are in the next slide. And we learn in different ways. Learning is not a one size fits all thing. Those of you that, took a psychology class at some point may remember the name Pavlov. Pavlov. Pavlov was the guy who gave dogs food pellets. And when he did it, he rang a bell. And it got so that when the dogs heard the bell, they started to salivate. Because what had they naturally done in the presence of the food is they salivated. When he paired the food with the bell, now when you rang the bell, they salivated to the bell. That type of learning is one type of learning. It's learning by association. I'm associating the bell with I'm going to get the food. Okay? The second type of learning, you might remember a guy called Skinner, B.F. Skinner. And B.F. Skinner said that we learn best through reinforcement, as in, if right after your child throws the ball, because that's what you're trying to teach them to do, you clap and give them a high five, that's reinforcement. It makes it more likely that they're going to repeat that behavior. That's called reinforcement learning or operant learning. The third type of learning, you may remember less about this guy unless you remember the Bobo doll. Bobo dolls, I recently saw one on an ad somewhere. Bobo dolls were these things that looked like a clown, and they were like those toys that you punched the toy and they had a sandbag in them and they'd come back up at you. So you'd hit it and it would come back up. It was called a Bobo doll. And a psychologist by the name of Bandura discovered that if you showed children how to play with toys in a violent way, they played with toys in a violent way. One of the toys they used was a Bobo doll. If you showed children how to play with toys in a peaceful, calm way, that's how the children played with the toys. That's called modeling. That's the third way we learn. So we learn by association, by reinforcement, or we learn by modeling. But in order for the brain to develop, it needs rest. When you bring your infant home, it's sleeping like 20 hours a day. As time goes by, your child needs less and less rest. Maybe. And that's where it can be different for a child with a hearing loss. They may, in fact, need more rest for a longer period of time. The brain also needs nourishment. And by that, think of food as fuel. And what is that food? Kids with hearing loss often have allergies. Kids with autism spectrum disorders often have allergies that are not so obvious that they break out in hives or can't breathe, but they subtly affect how the child's brain is developing, and as a result of how the child learns. Okay, next slide. So here's what we know about brain development. The first things we learn are concrete and literal. This, by the way, is sometimes a problem because this can be a place where kids with hearing loss get stuck. Concrete and literal. That means I don't have the ability to do abstract inferential thinking. Now, let me put that in a developmental perspective. Concrete, literal thinking persists until somewhere between the 12th and the 14th birthday. Concrete, literal thinking persists somewhere between the 12th and the 14th birthday. Concrete means I can answer questions that are fact-based. If I say the quick brown fox jumped over the lazy dog, I can tell you who jumped over who. That's concrete. That's literal. Now, I mentioned that people learn across modalities. Modalities are how we present information. So right now I'm presenting the information auditorily for those of you in the audience who can hear, and I'm presenting it visually. You can see the PowerPoint, right? So that means the roughly 50% of you whose brains were born with a preference for visual learning, you're benefiting most from having the PowerPoint. For the roughly 50% of you who were born with a brain preference for auditory learning, you're benefiting more from hearing what I have to say. Now, again, children who are born with hearing loss can have a brain that prefers auditory input. It seems counterintuitive, but it's very possible. And I think for some young deaf children, that becomes a stumbling block to their later ability to develop the ability for abstract and inferential thinking. But we also develop and learn, the brain develops tactily. Here's what I mean by that, is that the largest organ of the human body is the skin. Think of the information the skin gives you. All of you are likely sitting down while you're watching this presentation. Well, what that means is that you're sitting on something that most of us call a chair. Some of you might be sitting on a floor or a couch, but something that supports your body. And you were not aware of the pressure of the chair on your body until I just made you aware of it. Most of you were unaware of it. And some of you are in an air-conditioned room. So despite how humid and hot it's been the last few days, you feel cool. Whereas others of you are not in an air-conditioned space, and you were trying to ignore and overlook the message from your skin about how hot you were until Dr. Lisa made you aware of it. That's tactile learning. Kinesthetic learning, think of it as movement learning. They say that once you've learned to ride a bicycle, for example, you'll never forget how to ride a bicycle. Well, at my age, I'm not sure I want to test that, but yeah, okay, I'll believe that. A lot of people who haven't gone swimming in a long time, they get in a swimming pool or a lake or wherever, and they remember how to do it. That's also sometimes called procedural learning, because I can remember the procedure, but that's also messages from your body. It's messages from your muscles. It's messages from the nerves that remind you of the process of how to do something. These are all really important parts of understanding the brain. Okay, next slide. Any questions, anybody? All right. So when we're looking,
I'm sorry, I just have a quick question. I was just starting to type it into chat. When you talk about abstract thinking not being available, I guess, until they're, you said 14, 12 to 14?
between 12 and 14.
So I'm just curious, the object permanence experiment where, you hide something under under a blanket or something, and a 3-year-old won't realize that you don't know where it is, but a 4-year-old will realize that someone who just came into the room and they're kind of in on the secret. So that's not considered abstract thinking. That's more of a perspective.
No, that's what we refer to as theory of mind.
Okay. Yeah, I've heard that term. Okay.
And I could do an entire workshop on theory of mind, but theory of mind is essentially what you just described. It's the idea that even if you show a 3-year-old that you're hiding it, and then you distract them and ask them where it is, they may or may not remember it. But a 4-year-old who's, as you pointed out, in on it, is going to be able to say, well, it's right there. That's theory of mind. Abstract inferential thinking is the ability to develop a hypothesis about something, figure out how to test it, implement that test, and then evaluate whether or not it worked. We now are calling some of this executive functioning, executive functions, but this is based on the work of Piaget. And Piaget really began to understand that up until around age 12 to 14, you can't really talk to a child about liberty, justice, freedom. Concepts like death are not real to young children. They may get that the person hasn't come back, but they may be sort of like, now I'm dating myself, but the Road Runner cartoon. Wile E. Coyote got smashed under that rock, but he kept coming back. To little kids, that's conceptually death. To a kid between 12 and 14, they're starting to get the permanency, the conceptual, the inferential, the abstract part of a concept like death. Does that make sense?
That's very interesting. Thank you. I'd love to have you do that theory of mind one sometime. We'll have to talk.
Okay. So when you're looking at developmental milestones, I pointed some of them out earlier, that, typically a child by 1 year or 12 months, that child is going to use one word in a telegraphic manner to get their point across. Two words by age 2, 3 words, and then language pretty much takes off. So if you're looking at developmental milestones for a child with a hearing loss, here are some things you want to ask yourself. Does my child look and act like other children their age? And, for some of you, if your child with a hearing loss is your first child, you may not have that reference point. Is your child as physically strong as other children their age? Are they as coordinated? Is your child as curious, as inquisitive? Do they question as much as other children their age? And does your child initiate interactions with others? And if they do, what happens? Anybody want to comment on any of those questions before we go on? Because here's what I'll tell you I hear from parents. I hear from parents that sometimes they feel like their children do not look and act the same as other children their age. That's one of the things that makes them concerned for their child's development. While their child may seem as physically strong, because they're not as coordinated, they aren't able to control their bodies in the same way. They can't do things physically that other children their age can. And their child seems to sit back and watch a lot. They don't seem to get in there with the other kids as much as their hearing peers do. They don't ask as many questions. So as a result, they don't seem like they're as interested in their world. And oftentimes what I hear from the parents of deaf and hard of hearing young children is that their interactions with others often end up with some sort of physical interaction. So their child goes and pushes a kid away from something, or their child goes up and attempts to say something maybe to a hearing peer and the other kid just ignores them. Those are the types of things I hear from moms and dads and caregivers. Okay, next slide. Really important in understanding development that we develop physically, mentally, emotionally, socially, sexually, and spiritually. That's in a later slide, but I'm going to touch on it now. Physically, mentally, emotionally, socially, sexually, and spiritually. Here's the problem. Your brain can only pay attention and develop in one area at a time. So sometimes I hear from moms and dads of young children, well, my child was babbling and then they stopped babbling, but now they're up running around. Or my child was running around and now they're sitting all the time, but I can't get them to stop talking. That's normal, because the brain can only really work on developing one area at a time. Children also develop at different rates within the normative framework. The normative framework being that somewhere between 9 months, for example, and 15 months, most children will utter their first intelligible word, somewhere between 9 and 15 months. It's not that it's exactly on their first birthday that they do that. So children develop, maybe they were already walking at 9 months, but they didn't start talking until they were 15 months. All of that is within the developmental framework, though at opposite ends, right? Plus, we know that there are stages of development. There's the infant, the 0 to 2-year-old. There's the toddler, the 2 to 5-year-old. There's the young child, the 5 to 8-year-old. There's the middle child, the 9 to 12-year-old. Then there's the teenager, and God help you at that point. So children go through stages, and they have tasks at each of those stages. And if they skip a task, well, here's a problem. You can't really skip the task. You have to go back and fix that. So if for a lot of children with hearing loss, what gets skipped is language developing, you've got to go back and remediate that. And that can be very difficult to do because their little brain is already taking off in some other area. But here's what you need to remember about early childhood development. You are going to see obvious and sometimes what seems to be very rapid, almost overnight changes in your child every 6 months. And, you know, we say the terrible 2s. Honestly, I think the 3s are much worse, because by 3, they have a lot more to say. They've learned the word no, can use it pretty effectively, And they can get around a whole lot better than they could when they were 2. So we say the terrible twos, but we're usually talking about children somewhere between 2.5 and 3. So look for obvious changes about every 6 months through infancy and early childhood. So that's that infant to 5-year-old period. Because think about it, you know, here in Connecticut, you can enter kindergarten at 4 years old, provided you turn 5 by December 31st of that year. Well, if your child is 4 years old and 4 years old, 8 months, when they start school as a kindergartner, that's a very different child than a child who's 5 years, say 3 months old when they start kindergarten. That's like teaching 2 different classes. If you have a whole lot of 4-year-olds and a whole lot of already 5-year-olds, because that 6-month period means huge differences in brain development and in development across the areas of physical, mental, emotional, social, sexual, and spiritual development. Huge differences. Okay, the next slide. So for kids with hearing loss, one of the first things I want you to think about is the etiology. Why does my child have a hearing loss? Because etiology affects those developmental milestones. The most obvious example of that is prematurity. If a child has hearing loss because they were premature, they are going to look very different than a child who has hearing loss because their parents are deaf, their grandparents are deaf, their aunts and uncles are deaf. They're going to look very different in terms of their development. All right, Liz is asking me a question. Can I please explain what? I can't read the whole text or the whole thing, so let me look. Can you please explain to our audience what etiology means? Sure. Etiology means cause of deafness. Why? It's answering the question, why is this person deaf? Why do they have a hearing loss? Was it because they were born and had a severe infection of some kind and they were given a powerful antibiotic like gentamicin, which is known to rob a child of hearing? Is it because they have a genetic condition, one of the sequela or results of which is hearing loss? Is it because they have had multiple ear infections early on and it did damage to the very fragile inner parts of the ear? Is it because they were born without a cochlea? I mean, there are lots of possible reasons, but knowing that affects it. For example, there are a lot of genetic syndromes and a lot of physical syndromes. I think of one, Pendred syndrome. Pendred syndrome is actually a thyroid disorder. And that thyroid disorder, one of the results of that is a person is deaf, has some level of hearing loss. What if a person has Usher syndrome? Usher syndrome is a genetically carried syndrome that's going to affect how a person develops, not only in infancy and in early childhood, but across the lifespan. So the more you know about the why, the better off you are. I'm seeing someone saying charge syndrome. Yeah, I mean, that affects more than just their ability to hear. It affects cardiovascular, it affects gastrointestinal, it affects them globally. And knowing that is going to help you make decisions about treatment, about programming, about education. I'm going to read Kate's comment. You're right. Charge syndrome, sometimes called charge association, is one of the only syndromes that impacts every single sense. You're absolutely correct. And Liz is talking about her daughter Sage having deaf infertility syndrome, which is really, she's right, it's pretty fascinating. And understanding what other impacts that could have, both short term and long term, are really important, because some of these etiologies or causes are going to mean that you're going to have to find a way around something for a child to be able to do something, because they're not going to be able to develop a skill in a typical way. We also want to look at developmentally, when was the hearing loss identified? And right now I'm talking not about your identification, moms and dads and caregivers. I'm talking about, when did the professionals finally board the train with you and say, oh yes, this child has a hearing loss? That's the important date from the perspective of, now are we going to apply some treatment? So that's, when was amplification provided and when was it used consistently? You know, it's really, really hard to get young children to wear hearing aids or other devices, eyeglasses, anything. I mean, one of the things that I've been most curious about, and I'd love to figure out a way to study this, and I haven't figured it out yet, is the acceptance I'm seeing in very young children, preschool age kids, of masks during the COVID pandemic. I am really surprised. And I hear from my colleagues who are working in schools that, you know, they'll say to a kid that they're testing, you can take off your mask in my office. And the kids are like, no, 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 gotta leave my mask on. So I'm fascinated that children have really relatively easily adapted to that. But the one thing that I realized about that is exactly what Pat's saying, is that adults are doing it. You know, if you're the only kid in your classroom wearing that FM or wearing those hearing aids, why would you want to do that? Because one of the first needs of humans is to belong. And if I look different than you, if I act different than you, if I have something different than you that nobody thinks is cool, why would I want to do it? And also realize that this is the importance of early intervention. These developmental milestones are affected by those. The quicker you get the intervention in place, the more it's done with fidelity. That means the more you do it the way it's intended to be done, the better off the child is. I mean, we have a saying that says practice makes perfect. That's actually not true. It's perfect practice that makes perfect. If I practice it wrong, it doesn't make perfect. Okay, next slide, please. So here are some of the things that developmentally a child with hearing loss, as many of you already know, have problems with. They have problems localizing sound. Even with a mild unilateral hearing loss, I may not be able to find your voice in the room, so I may turn completely around to find you. Your child may also have a delayed response to sound. They may not babble or speak, and they may not, interestingly, respond to loud sounds in the environment. And that includes with amplification on, because here's the thing. If from the time I was born until the time I started using amplification, my brain was not getting access to sound, and you suddenly give me access to sound, I don't know what that is. I don't know what that is. So I may not startle to it. I may not react to it at all because I don't know what it is. It has no meaning for me. Alternately, some of your children will get very fussy or very excited in loud environments. That'll wind them up. And that can be because now I'm hearing it and it's uncomfortable. It's too much. My little brain is on overload. You may also see in very young children with hearing loss that they stare intently at people in a way that makes people very uncomfortable. You may also find, we now realize that a lot of children with autism spectrum disorder do not look at people's eyes. They look at their mouths because that's where the information is coming from. I've never seen a study of young kids with hearing loss, young deaf kids, but I have seen young deaf kids staring at people's faces. And what I see is they're staring at the mouth because the mouth is the thing that's moving. The eyes aren't moving. You may also see that vocabulary is very slow to develop. So when you expect a child to have 10 words or 50 words receptively and expressively, they don't have them yet. Okay, next one. Developmentally, kids who are deaf have problems with balance. That often has to do with the etiology, the cause of the deafness. And even when they want to do things that require balance, they cannot necessarily do that. They also, as I mentioned earlier, tend to tire more easily because it takes a lot of effort and energy to try to learn to hear and to try to learn to speak and to try to learn to communicate in general. As a result, and this is really important, if you hear that a young child, somebody suspects they have an attention deficit hyperactivity disorder, make sure you're saying to that mom or dad, get your child's hearing tested. Because lots of kids who actually have a hearing loss come across like they have ADHD when they don't, because they're more physically active. So they look like they're very hyper when they're not hyper at all. They can't hear. So they're trying to get more input. They also seem to get more easily frustrated. Kids with hearing loss, they have a lower tolerance, but again, they're more tired. They're having to put more effort and energy into paying attention. And their little bodies are having to learn how to hear as well as learn how to process information. Because a hearing baby, from the moment it's born, is learning to hear. A child with a hearing loss isn't getting that benefit from the moment they're born. As a result, they're more likely to strike out. So I often hear from parents of young deaf kids that, my kid hits more than their brothers and sisters did. Of course, they can't yell across the room to get someone's attention. That's what they need to do. And one of the things that can be really helpful is use the preemie guidelines. So what would a premature baby look like? What did we do? And do you see what I mean? Well, what would we do if this baby had been born prematurely to enhance their development? And those guidelines can be really helpful, even if the cause of your child's hearing loss is not prematurity. All right, next slide. You're not asking questions, so I'm going to keep going. So, concerns and responses. So what do you do about it? Here's what I want you to think about. Has your child's behavior changed some way in a very short period of time? Think of this as a noticeable change in behavior. In other words, if they were running around like a whirling dervish, are they all of a sudden sitting more than they were? Are they all of a sudden more quiet than they were? Or alternately, if they were really quiet, are they now all of a sudden up and rambunctious? And did that seem to happen really quickly? Is everyone telling you everything is fine when your gut says it's not? Ask yourself, do you trust the team? Do you trust the team of people with whom you're working? And another time to know that it's okay to be concerned is, are you worrying all the time? If you're losing sleep, time to be worried. Okay. Think about that in particularly the first one. Has there been a noticeable change in your child's behavior in a relatively short period of time? All right, let's go to the next one. Now, I already made mention of this, and I had said that I wanted to touch on the fact that we should not just focus on language. These are the 6 areas that people develop: physically, mentally, emotionally, socially, sexually, and spiritually. Physically, in that 0 to 5 time span, their bodies are getting physically bigger. They have tasks of learning to walk, learning to talk, learning to feed themselves, learning to dress themselves, learning to control their toileting habits. In that same period of time, mentally, they need to learn to pay attention. They need to learn to learn. They need to learn how to remember things. In that same period of time, they go from crying and screaming to hopefully using words to express their needs and wants and express how they feel, remembering that for young kids, happy, sad, mad, and for humans in general, happy, sad, mad are the 3 basic emotions, and everything else stems from that. Sexually, we don't like to think of infants and young children as sexual beings, but they are. And we provide powerful societal messages about sexual behavior from the time a baby is born. What I mean by that is, think about when you change your child's diaper. Where do their hands go? And what do we have to do? We move their hands out of the way in order to put on a clean diaper. That is a powerful message about sexuality. We also, when we think about sexuality, we also need to think about gender. We give powerful messages about what boys do, what girls do, what boys don't do, what girls don't do. And then spiritually. Spirituality is a very abstract concept, but typically, depending on your faith background, there's some sort of ritual that has to do with the birth of a child. And there's some ritual that has to do with introducing them to your faith community. So think of your child across all these areas, more than just a person that needs to learn language. Okay, next slide. So here's what you can do if you're concerned. Play matching games. Matching games are great, and you can match anything. You can match toys, you can match cards, you can match colors, you can match forks, you can match knives, you can match spoons, you can match coins, you can match anything. Play balance games. Because kids with hearing loss are more likely to have problems with balance, they need to work on it. Help them stand on one foot. Help them jump on one foot. Help them walk across something holding your hand. Play the name game. Everything in the environment has a name, has a label. I even tell moms and dads, label everything. Particularly, by the way, for kids with autism spectrum disorders, sometimes they're hyperlexic. That means they can read words before maybe they can say them, and sometimes before they can understand them. So name everything. Oh, look at that. That's a keychain. Keys are something you use to put in a lock. Signs all over the house is perfect. Limit their screen time. Here's why I say that. Screens, and I mean, right now, you're probably all pretty tired because we've gone for more than an hour. And the average adult, by the way, can only attend for about 50 minutes. So we're already over your attention span. So I hope I'm at least mildly entertaining so that I can keep you for a few more minutes. Limit screen times in little kids, because here's what happens when we're exposed to screens. If we were face to face, you would be able to, your brain would process micro expressions, small changes in the muscles of my face that show what I'm feeling, that give the tone of the message. For those of you who sign, that's really pretty obvious, right? Because in ASL, the markers are all in the face, right? So what happens when you're on a screen is there is a delay, a slight delay. Have you ever watched TV when the audio and the video aren't synced? Because of that slight delay, your child's brain is always processing behind when it's on a screen. You understand conceptually what I mean? That slight delay that you couldn't even measure if you were watching it is there. And that slight delay makes neural changes in the pathways of their brain. And those changes can be enduring. Also, think about things that they see on screens. I mean, Sesame Street. Most of you know what Sesame Street is, even if you weren't raised on Sesame Street. Sesame Street is great for kids because it changes quickly. One of the skills we need young deaf children to develop is the ability to sustain attention, the ability to look and continue to look until they get the whole message. If all I'm ever exposed to is something that quickly changes, the neural pathways in my brain aren't able to sustain attention. Require social interactions. Require your child to respond to questions. Require of them everything you would of your hearing child. If you expect that your hearing child is going to say hello to an adult in the environment, expect your child with hearing loss to do the same thing. Really important, as an integrative medicine specialist, I'm very concerned about watching for reactions to food, drink, medications, and the environment. Because as, like I mentioned, milk, many kids with various etiologies can have food sensitivities that are not allergies. It's not going to make them sick if they eat it, but they act differently after they have certain foods. A common culprit, for example, is red dye. Red dye is in most ketchups. If your kid eats a lot of ketchup and you notice that after the meal, they're a little wound up, try giving them an organic ketchup that doesn't have the red dye in it. Could it be that simple sensitivity? Okay, next slide. Some more tips. Allow lots of time for play. We spend way too much time in the United States teaching preschool readiness skills. Readiness skills mean ready to read, ready to do math, ready to write. Play is important. Play is one of the things that socializes people and makes us good human beings. Label things. One of the things to do if you're worried is see if you can pin down that etiology, that cause. Why does my kid have a hearing loss? Require amplification use. I know it's hard, but if you start with your child at meal times, when they're motivated to eat and you stick the hearing aids on them then, they're more likely to tolerate for at least the meal. Then it's 5 minutes before and 5 minutes after, and you add on. I cannot emphasize the next thing I'm going to say enough. Require your child to learn English. Require your child to learn English. I have nothing against the American Sign Language, the language of the deaf community in the United States. I have nothing against it. But the deaf adults who succeed are those who master English. They can read it, they can write it, and they can succeed because they can compete in jobs when they become adults. Use manipulatives, picture schedules, use the actual item, use pictures of things that you match up so that your child can feel what you're trying to teach them. They can feel it in their hands. And most of all, make it fun. Whatever you're doing with your child, make it fun. Next slide. Few more tips for you. Worry only 1 day a week. Enjoy your child the other 6. Remember, you can call a team meeting at any time. That's your right. Do not expect the team to agree with you. But remember, you are the best expert on your child. So prepare for that meeting. Also understand that your child is different than when they are not with you. When you are not there, your child does not act the same. And some of you are going, whew, thank God for that, because they're terrors at home. And that's exactly what you want. You want to hear, they did this, this, and this at school, and we're really proud of them. When you're thinking they came home and they fell apart and they dissolved into tears and I couldn't get them to do anything. That's perfect. That means you've raised a well-socialized child. But understand that even if the child displays a skill for you at home, if I'm in the school system and I can't see that, I can't document it. So it's important that the child begins to generalize. That means do the same things that they're capable across settings. Okay, next slide. This one's hard for moms and dads. Don't worry about the labels. Don't worry about the diagnosis that the pediatrician or the developmental pediatrician or the psychologist gives your child, or that they give you on the IEP or the 504 plan when your child enters school. Don't worry about those labels. Think of those labels as tickets to services. That's what they're there for. They get you the services that you need. Worry about the progress. Insist that your birth to 3 provider, that later your special education provider or 504 providers insist on measurable outcomes. Because if you can't measure it, how do you know whether it's better, worse, or the same? Enjoy your child. Limit educational activities and times in the home. You're their parent. You're their caregiver. You're not their teacher. You're not their preschool provider. You're not their birth to 3. Yeah, I know the birth to 3 provider says do it every day. And yeah, that's a good idea, but as long as you're making it fun. So make sure that provider leaves you a fun way to enhance your child's language, a fun way to enhance your child's motor development, a fun way for you to stimulate them cognitively. If it's not fun, if it's not play, go back to the drawing board and ask them to redesign it. Focus on everyday things for your child that make them good people. Next slide. My biggest, most important tip is enjoy your child. The time flies. Time flies, and before you know it, your child's going to be asking you for the car keys. And, you know, you want to make sure that that child is ready for that responsibility. Next slide has on it some developmental milestone, some websites where you can get some really, you can go to the next slide list, has some pretty good developmental milestone guidelines. So the importance of those is being able to look at your child and compare your child to what they say. What should a 1-month-old be doing? What should a 2-month-old? What should a 2-year-old be doing? And then looking at your child across the areas and saying, okay, how does my child measure up? Can they do most of the things that are listed here? Or do they have gaps? Because if they have gaps, that's something to go back to your providers with and say, okay, I noticed my kid has a gap in this area. How are we going to fix that? Because that's really what you want to do. And these are 3 particularly good websites that I think give you a variety of perspectives across those developmental areas. And then finally, next slide, I'll take any questions. I appreciate your attention. And the very last slide is my contact information. That's my email address at University of St. Joseph, where I'm an assistant professor of psychology, and that is my office number at University of St. Joseph. And although I'm remote at this point, I do get notices that people have called. So thank you for your kind attention. I'll take any questions anybody has. Did someone ask about my fluency in sign language? I worked at the American School for the Deaf for over 25 years. I've been working in the deaf community for almost 40 years. Yeah, next year it will definitely be 40 years. So I have a little bit of experience. I do evaluations in my private practice for school districts, the Department of Children and Families, the court. I've done some forensic evaluations for deaf defendants in a variety of situations. So contact me if I can be of some help. And thank you to the interpreter. It's very hard to present and sign for yourself at the same time. And I was watching Michael sign because I always watch my interpreters in case they get stuck and are like, how do I sign that? Or for spelling of things. She did. Hello, Sage. That's awesome. So does anyone have any questions?
Alvin saying, hi, Sage. Hello.
And I have to say, geez, I remember Alvin when he was a little boy.
Yes, that was a long time ago. Yes, you do, Dr. Lisa. Thank you. How are you?
Well, I think we're both getting a little bit older. I'm not sure, but I think a little bit older. So.
Yeah, a little.
Well, thank you, everybody. And, thank you, Liz, for the opportunity. I'll hang in here while people sign off if someone has a question for me.
That sounds good. And Alvin saying, thank you so much for the wonderful information. I appreciate the presentation. Thanks so much.
You're welcome. It was good to see you, Alvin.
Likewise. Thank you.
Bye.
Bye-bye.
Ah! me get the right view. Let's see. Hi, how are you? It's nice to see you. Wow. I think you've gotten a little bit taller. That's great. So anyone have questions?
Would you like to ask any questions, Sage? The video was freezing up for me. I'm not sure if you saw.
Yeah, it was freezing up for
Okay.
me too. That was freezing for me again. I'm not sure what she signed.
Can we sign what? Your picture's freezing a little bit. Sign what? Oh, Sage is saying, I can sign.
I know, I see that. That's wonderful. I'm happy to see that. How about your sisters? Are they signing with you? Yes. Oh,
Mhm.
that's exciting. And I bet you have many deaf friends now, right? That's wonderful. I'm happy to hear that. Do you like school? Perfect.
Yes. She's going to be starting kindergarten in August, so pretty soon.
Wow. Wow.
You're so smart.
What a big girl. Whew.
Mm-hmm.
Well,
Right, and now you're 5, right? You just had a birthday?
just had a birthday?
It was a long time ago. Pretty soon you'll have a birthday.
That's great. Sage, where is Daddy? Oh, he's
He's at
working. Okay. Well, be sure to tell Daddy that Dr. Lisa says hello, okay?
Okay.
That for me?
Yeah, her dad is out in the garage, so.
Okay. All right.
Oh, in the
Submarine.
submarine, sorry.
Submarine. Yeah, that's what I thought. I thought submarine. All right. Well,
Yeah, it's hard without the content, the context still. Thanks.
that is a problem. Yeah, I knew what she meant because I knew where Dad was.
Sure.
So anyway, well, it was good to see you, and I hope this is what you were hoping for, Liz.
Oh yeah, it was awesome. Thank you so much, Dr. Lisa.
All right. Well, good night. Bye.
Good night. Thanks again. Thanks so much. Thank you, thank you, thank you.
Thank you again, Michael.
You're welcome. It was my pleasure. Thank you very much.
Bye.
Take care.